I'm glad you brought up this other trial or this other paper. This is the number 3 one we were going to talk about out of 4 with the relationship between anemia and symptoms. And this is a very technical kind of a study. So one thing I wanted to say about it is that quality of life is sometimes misunderstood as a really subjective thing that you can't measure or something that you don't know what to do with it in clinical practice. So I just want to make sure that our audience realizes that these studies that use PROs as clinical trial endpoints or to better understand the patient experience of illness use very well-validated survey tools that you could think of like laboratory tests or imaging studies. It is a subjective concept, but the way that these tools are developed, they're very reproducible and reliable. A lot of work goes into what's called the psychometrics, such that if you read the question and you read the question and I read the question, we all interpret it in the same way and answer it similarly. So I think a lot of people misunderstand and don't give enough credit to these kind of PRO data. So I agree with you that this is a really important, powerful study that says if you have a hemoglobin of 10 or more, you have much better quality of life. That's not sort of hand-waving wishy-washy. It's a very reproducible, well-validated PRO tool. So the EORTC tools that are used by the EMA to support regulatory approvals, the FACET family of questionnaires like the FACT-AN, which is an anemia subscale kind of a tool, very well validated, considered by the FDA to support regulatory approvals. This is really good science, so I hope that our listeners and viewers here realize that this is pretty important for the field, like you said.
Well, and I love that you brought that point up because keep in mind, we're not curing any of these patients.
No.
They're living with this disease, as we've mentioned, many times for 5 to 8 or more years of their lives. And these therapies, as far as we know, are not even necessarily disease modifying. So,
right.
I'm not treating a number. I want to really improve how my patient's feeling. And I think we have really looked at things like hemoglobin. It's easily, to your point, very easily quantifiable. But now that we have done, more work with these quality of life assessments moving forward, to me, that's a very important endpoint for my patients.
What's interesting, though, in thinking about day-to-day practice, and I'm curious to hear if you've had this experience too, when I reflect on these data, which show there's a clear and strong association between hemoglobin level and overall quality of life, fatigue, symptoms, I also definitely see on an N of 1 basis from patient to patient, some people who just absolutely do not tolerate a hemoglobin below 10.5, and they feel miserable and they can't even function. They have fatigue, they have dyspnea, and I can't even transfuse them. And I think, am I causing harm if I give them an EMA or an ESA? Is there going to be an increased risk of a vascular event or a cardiovascular issue? Then again, I have one patient who comes to mind who just adamantly refuses transfusion until they're in the 5s or 6s, and they feel fine, and they're out playing with their grandkids, and they say, no, I'm good, doc, that's all right. And of course, I'm wanting to minimize transfusions. I don't want people to get allo-immunized, where then we can't match blood units anymore, and then we're in trouble. I don't want them getting iron overload, and we face these problems in patients who live 5 or 10 years with MDS who get a lot of blood products. But juxtaposing the PRO results of that study with what we sometimes see in clinical practice just reminds us that every person is different and you still have to meet them where they are. So to your point, Andrew, individualizing the target, but not settling and aiming for more, that's, I think, really what we do need to get to as a field. So how do you think we get there? So I'm thinking, for example, there's combination trials, EPO plus luspatercept. There's the luspatercept no ramp up trial. There are lots of other things happening. What do you think?
Yeah, no, it's a good time to be interested in making low-risk MDS therapies better because there are a lot of tools to use. I do think that some of this heterogeneity in individual patient tolerance of anemia really has been a challenge for how do you develop drugs in this space. And periods of transfusion independence have been one way to measure that, but you have to recall, even in second-line therapy, the placebo arm doesn't always do so badly.
Right.
And I think that reflects this, that there's a lot of heterogeneity in just using a number. I think we have seen the field shift much more to incorporating PROs universally in trials. And so we're starting to see how that can better clarify certain goals. I'd like to see ongoing novel endpoints, really. One of the biggest burdens, I think, is coming to see me. So can we look at reduction in days in clinic? Can we look at ways to show other metrics of you living life? There's a lot of data on looking at biometrics. We're all attached to a computer 24/7. Can you look at steps or look at movement?
We get a lot of steps in at ASH. I'm already at 10,000 today. The day's halfway done.
But I think that there is interest, and that might become even more important when we look early in disease. Mm-hmm. So looking at not just a number, because if we're looking at pre-transfusion dependent patients, we're really going to have to capture a global benefit. And I think that that's important as we try to figure out what could the endpoints be in earlier phase studies.
There have been some interesting ones that I've seen lately. I don't know if you've seen some of these too, and I'd be curious to get your input on this. Like the twist, the time without symptoms and toxicity, but that's a little bit complicated and confusing to understand. The one that I saw most recently, and this was in the context of older patients with AML, that I thought was just really clear and meaningful, especially if you're the patient, was this concept of time toxicity, but just days at home. In other words, a day that you didn't have to come to the clinic, that you weren't in the hospital, that you weren't sitting in an infusion chair, getting zonked with pre-meds before you get your transfusion. How many days are you at home versus how many days are you in contact with the healthcare system? And it's a little more difficult to operationalize that on a trial, but from the standpoint of real-world data and what you would care about if you're the patient, it's that. It's, do I have to pay for more gas and pay for parking and sit in traffic on the turnpike for an hour? That's what really impacts our patients' lives. So.